He will not force.
Thanks very much, Freddie. So I'll tell you a little bit about how I came to be here, but first I wanted to tell you a story. When I finished medical school, I didn't really know what I wanted to do. I thought maybe I would do internal medicine. And in our fourth year of medical school, we entered the hospital for our clinical rotations, and as luck would have it, my first rotation was neurosurgery. And I really had no appreciation of what surgery had to offer as a career, and I was enthralled when I did my first rotation. And at the end of that rotation, I sat down with the neurosurgeon who was responsible for the medical students, the clinical clerks. This is a man who was known for his bedside manner, but not necessarily in a way that you would want to be known for your bedside manner. And we went over my rotation, and at the end he said to me, "So what are you thinking of in terms of a career?" And I said, "Well, neurosurgery seems really interesting." And he paused and he looked at me and he said, "You have to be smart to go into neurosurgery." So my next rotation was orthopedics, and I stand before you as a humble orthopedic surgeon. I love orthopedic surgery. 80% of what we do as orthopedic surgeons, I believe, is among the most quality of life enhancing, cost-effective interventions in all of clinical medicine. But there's 20% of what we do that maybe we shouldn't do, or things that we aren't doing that we should do. And that's where I've spent my career, largely focused on evidence-based practice, evidence-based surgery, evidence-based orthopedics. But I think it's time to change the conversation, and that's what I want to talk about today. So as Freddie said, I spent 25 years at this hospital in Toronto. This is the Hospital for Sick Children. This is a watercolor painted by a colleague of mine, Mercer Rang. And then I was lucky enough 2 years ago to come to this organization, the Nuffield Department of Orthopedics, Rheumatology, and Musculoskeletal Science. And I've been very grateful for the kindness and the professional opportunities. But for family reasons, I'm going back to Toronto with some disappointment, but that's what's best. So, fundamental changes to orthopedic clinical practice. What has changed? What are the paradigm changes within orthopedics? Well, clearly the introduction of general anesthesia 120, 130 years ago. In orthopedics, about 50 or 60 years ago, the introduction of minimally invasive approaches, and I think for many surgical specialties, this changed the way surgery was and is and will be performed. So, what's the next fundamental change? Well, I wonder if it's using best evidence to direct us to do the same thing for the same condition. So how do we, I mean surgeons, but definitely orthopedic surgeons, perform belief about treatments? And up until recently, and I would say even to the current day, there's an acceptance and even promotion of divergence in opinions about treatment recommendations. Surgeons stand with pride and say they do something completely different for the same condition than someone across the aisle, across the city, or across the country. In orthopedics, this has come about because our literature has been reliant on uncontrolled case series, and a case series can always be invoked to support whatever opinion you have. Now, don't get me wrong, there have been major advances in orthopedics because of uncontrolled case series, so-called level 4 evidence. The total hip replacement, John Charnley, 1972. The internal fixation of fractures from the AO group, the instrumentation of spine, Paul Harrington. And in my own specialty, pediatric orthopedics, the Ponseti treatment for club foot. You don't need a randomized clinical trial to know that the Ponseti treatment is better than what I used to do when I started my practice, which was an extensive release for the club feet. But when you look at these major advances, they're all more than 50 years ago. So I liken this the low-hanging fruit. You don't need a randomized clinical trial to know the total hip replacement was better than everything went before. The problem is we've probably picked most of that low-hanging fruit, in which case the case series is no longer as useful or useful at all for us. And I would suggest we need to go to another paradigm, something a little more rigorous. And you'll be familiar with this, evidence-based medicine, and another Canadian colleague of mine who ended his career here in Oxford, David Sackett, and he talked about evidence-based medicine as the use of current best evidence from systematic research in making decisions about the care of individual patients. And what David was talking about was randomized clinical trials as this alternative methodology to answer these important questions. So, what is the status of evidence in orthopedics? And, for years the joke was, how do you hide a $50 bill from an orthopedic surgeon? Well, you put it in the peer-reviewed literature. But this is JBJS, the Journal of Bone and Joint Surgery, which is the most highly cited orthopedic journal. And this is the levels of evidence published in that journal by year in decades. And the gold bars represent level 1, uncontrolled case series. The red bars represent randomized clinical trials. Prospective cohorts is purple. Retrospective comparative studies is the green. And so what you can see is a substantial increase in level 1, up to almost 25%, but even close to 50% or more than 50% of controlled series, which means the case series is now less than 50% of the articles published in JBJS. So I think we're beyond the tipping point in orthopedics. The number and quality of randomized clinical trials, many of them originating from this center, such as the work that Matt Costa and many others do, is changing the evidence base for orthopedics. So if we accept that there is or will be an evidence base for orthopedics, how do we change our behavior to become more evidence-based? And I would argue we need to change the way we, surgeons, think, and we are going to need structures to help support that change. Now, this cartoon says, I want you to find a bold and innovative way to do exactly the same way it's been done for the past 25 years. So I'll suggest to you it's time to do something different when simply doing a well-performed randomized clinical trial, publishing it in a high-impact journal, and perhaps not seeing the practice change that we would like. So, I'm going to present to you some material, and I don't mean to provoke you. Well, a little bit I do. I don't mean to provoke, but I do want to challenge you to challenge the way we think as surgeons. So I'm going to start with a little audience participation. As a surgeon, I am a rational decision maker leading to logical opinions and correct decisions. Hands up. Okay? That means the rest of you are prone to bias leading to strong opinions and flawed decisions. So I'm going to start with an example. It's a bit of a tired example, but it is a good example. This is a seminal article for orthopedics. It was the lead article published in the New England Journal of Medicine. It was seminal because it was, I think, the first trial published orthopedically in the New England Journal of Medicine. It was also seminal because it was one of the first placebo-controlled trials in all of surgery. And Bruce Mosley was an orthopedic surgeon who practiced in Texas, and his group did no arthroscopic debridement for osteoarthritis of the knee, and yet across town, they did an enormous number. And he wondered, how could that be? So he and Nelda Ray did this randomized clinical placebo-controlled trial, and their conclusion was, in this controlled trial involving patients with osteoarthritis of the knee, the outcomes after arthroscopic lavage or arthroscopic debridement were no better than those after placebo. This was not greeted with enthusiasm by the orthopedic community. At the time, this was the most commonly performed orthopedic operation in the United States, and Bruce Mosley was vilified. He has an amazing talk of the lengths to which people went to discredit him personally and this study. So Artemis Ward said, it ain't so much the things we know that get us into trouble, it's the things that we know that just ain't so. So I'm going to start with a premise. And this is my premise. Surgeons are human. You're supposed to laugh, right? So I pulled this picture off the internet. These people all look like they're having a great time at this party. And coincidentally, they're all drinking the same beer. Now, for those of you who are looking forward to that beer tonight at the end of the week, you're now slightly more likely to reach for this beer than a competitor. This is called associative advertising. It's ubiquitous, and the reason it's ubiquitous is because it works. Without you even thinking about it, you now associated drinking that beer with being at that party, and they look like they're having a ball, and that's where you want to be. And if you drink this beer, you're going to have fun like they do. So I suspect most of you, or many of you, have read this book by Daniel Kahneman, and he won a Nobel Prize in economics for his work on behavioral economics, which is how we make decisions. And I quote from his book, "The notion that we have limited access to the workings of our mind is difficult to accept because naturally it's alien to our experience. But it is true, you know far less about yourself than you feel you do." You never made that association, but it happened inside your head without you being even able to be aware of it. And of course the corollary is it's easier to recognize other people's mistakes than it is our own. So what I'm talking about here is, let's presume we do or will have best practice. How do we get surgeons and clinicians to adopt that best practice? And that's what this is about. So I'm going to take you through 3 studies. The first is a study that we did in the mid-90s, early 90s, and we were interested in surgeons' opinions about indications for total knee replacement. Now, I'm a pediatric surgeon, but at the time this became an important research topic because total knee replacement is a very expensive and very frequently performed procedure. So we asked orthopedic surgeons, holding everything else constant, how do these 30 or so characteristics affect your decision-making to perform a knee replacement? And so what we found, for example, patient more than 80 years of age, a third of surgeons said it made them less likely to perform a knee replacement, a third of surgeons said it had no effect on their decision, and a third of surgeons that made them more likely to perform a knee replacement. Well, we found that in an astounding amount of disagreement. And we couldn't find any characteristic that was explained. It wasn't how recently they've been trained, it wasn't whether they did a lot of knee arthroplasty, it wasn't whether they had a fellowship in knee arthroplasty. Disagreement all the way across the board. So, more than a decade later, we repeated the survey. We went back to every orthopedic surgeon in the province of Ontario, and we asked them the same questions again. And what did we find? Well, almost the same amount of disagreement. Patient more than 80 years of age. A quarter said it made them more likely to perform a knee replacement, 50% said it didn't affect their decision, and 25% said it made them less likely. So again, pretty significant disagreement among orthopedic surgeons. But we did something different this time. We went back and resurveyed the surgeons 6 weeks after this and asked them the same questions. And this is what we found. When we look at the variation in opinion, there was a group of factors for which the groups and the individuals themselves agreed. We found a number of factors, such as age more than 80 years of age, where the variation was due to variation in opinions within the group. We found a number of variables for where the variation was both due to the opinions within the group, but also the opinions within the orthopedic surgeons themselves, and then a number of factors where most of the variation could be explained by surgeons changing their opinions 6 weeks apart. Now, the implication is, if surgeons change their opinions like that, potentially if you pitch up for a knee replacement, you might get a totally different opinion one week than you might get the next. And in fact, we found 50% of the variation in opinion was due to surgeons changing their opinion 6 weeks apart. Now, this is just a survey. We don't know whether this reflects actual clinical practice, but in fact, that wasn't the most interesting thing. The most interesting thing is we also asked surgeons, are you uncertain in your opinions? For the patient more than 80 years of age, only one surgeon admitted they were uncertain. Despite obvious uncertainty within the clinical community And 50% of the variation due to surgeons changing their opinions 6 weeks apart. Only one surgeon admitted they were uncertain. And you know the quote that's coming up next. Not always right, but never in doubt. So what does this first study say about surgeons? Well, our inability to accept and acknowledge uncertainty makes us willing to accept this wide divergence in opinion. And presuming all of us can't be right, it has to make us less likely to accept new information. We believe our opinion is right. In your opinion, it's just wrong. The second group of studies I want to present to you come from work on unmet need. As Freddie said, we did a lot of work on unmet need. We were interested in how many patients were out there who would legitimately warrant a total knee replacement but weren't receiving it. So what do we do? So we surveyed 50,000 people in 2 counties in the province of Ontario, and anyone who said they had a complaint in their hip and knee then completed something called the WOMAC scale. And for the joint surgeons, it's a commonly used outcome scale, and we used a conservative threshold of pain and disability that everyone would say, wow, gee, if you're that sore and that function limited, you'd be a candidate for a knee replacement. We then had those patients examined to make sure they actually had arthritis, and they had radiographs to make sure they actually had arthritis. And then they went through a decision aid in which they were said, you'd be a perfect candidate for a knee replacement. Would you be definitely willing to consider? And when we did that, we found that there was quite a bit of unmet need within the population. These were people who were perfect candidates and yet were not on the waiting list or hadn't seen an orthopedic surgeon to see whether they would warrant a knee replacement. But we found a really interesting thing. We found the unmet need was 3 times greater in women than it was with men. That was interesting. Why would there be this sex difference? And we thought, well, maybe it has something to do with the way female patients present themselves to their doctors. Or maybe it has something to do with the doctors. So, back to the survey. This is the one factor where surgeons universally agree. Patient sex had no effect on their decision making. So we challenged that. What we did is we had a man and a woman, both with knee arthritis, moderate knee arthritis. They went through a standardized patient training program to present themselves to physicians exactly similarly in every other way other than one was a man and one was a woman. Same age, same presentation, same social history, exactly the same. The patients themselves didn't know what the study was about. So they had no idea it was about surgeons' decision-making around patient sex. To make sure they were presenting and we sent them in blind to physicians' offices. So physicians didn't know they were study patients. I have no orthopedic friends anymore in Toronto. So we sent them blind into orthopedic surgeons and family physicians' offices. To make sure they were presenting themselves as they has been trained, we sent those patients to see mock family physicians. So we had family physicians who were true family physicians who were part of our study, who then the patients went to see and presented their history and physical, and we videotaped them with a camera in a Kleenex box to make sure they were presenting themselves exactly as we had trained them. And they went into surgeons' offices and they went into family physicians' office, and the outcome was, for the surgeon, you're a candidate for a knee replacement, or you're not. And for the family physician, I'm going to refer you for a knee replacement, or you're not a candidate to be referred for a knee replacement. So that was the outcome. And what did we find? Well, we found orthopedic surgeons were 22 times more likely to recommend the knee replacement for the man than they were for the woman. Now, I'll preempt the question, which is, does it differ for female or male orthopedic surgeons? Because that's always the first question. Now, we didn't have, as you can understand, there were relatively few female orthopedic surgeons, and it never reached statistical significance, but it looked like it was exactly the same. Whether it was a male or female orthopedic surgeon, exactly the same. Now, family physicians slightly less, but they were more than 2 times more likely to refer the male than they were for the female for a joint replacement. So what does this study say about surgeons? Surgeons' unconscious bias, because we don't believe, or I don't believe, that surgeons are consciously biased against women or in favor of men. We believe it's an unconscious bias, but we believe there's an unconscious bias that may play a role in explaining disparity for joint replacement. Disparity means there are women in the community who are perfect candidates and they are 3 times less likely to receive it than they are the man. And if it's true, then we need to address this to ensure that we have equal access for all. The third study I want to present to you was a randomized clinical trial that we did at sick kids. And idiopathic scoliosis, many of these children have surgery to correct the deformity of their spine, and the purpose is to straighten their spine as much as possible, and then we fuse it in the straightened position. And at the time of this trial, we had 2 instrumentation systems. We were a USS, Universal Spine System Center. That's what we did exclusively for children with idiopathic scoliosis. And a new competitor came on the market, something called the Moss Miami. Now, at this point, neither one of these instrumentations are on the market, but at the time, the Moss Miami worked by an entirely different biomechanical principle. And the question was, is it worse? Is it better? Is it the same? And there was another issue, which is the Moss Miami was slightly cheaper than the USS system. So I won't take you through the biomechanics, but we did a single center randomized clinical trial of 125 children, and I think 98% consented, which is, okay, doc, you want to put in this versus that? Go ahead. 24 hours after the surgery, we said to the surgeons, so, which one did you like? Surgeons were vastly more satisfied with the USS system than they were the Moss Miami. That's kind of interesting. A 42% difference in satisfaction. Why would that be? Well, we thought maybe it had something to do with the outcomes. So the primary outcome from this trial was change in quality of life. And if you look across horizontally, you'll see on this quality of life scale that the scores were virtually identical between the two at 2 years after the instrumentation. Okay. So it wasn't the quality of life outcome. There was nothing that could explain why surgeons so preferred the Universal Spine System, USS. Well, maybe it had something to do with function. Well, we use this scale called the activity scales for kids, and we look, and you look across horizontally again. No difference between the USS and the Moss Miami. Patient satisfaction. How did the patients respond? And if you look, it's a 1 to 7 scale where 1 is the most satisfied. If you look again horizontally, no difference between the two groups. So there was no clinical explanation we could come up with. So we went deeper. Maybe it has something to do with the ability to correct the scoliosis. So I told you these children have crooked spines. The instrumentation tries to straighten the spine as much as possible. Maybe the USS was better at achieving that. And we have a number of radiographic measures that we can use to evaluate our ability to correct the deformity of the spine. And they're all listed there. And again, as you go across the horizontal rows all the way down, except for a slight difference in lordosis, and not a clinically significant difference. And remember, there are a lot of comparisons here, so it'd be surprising if we didn't find one. No real radiographic differences. Well, we have a number of ways looking at the spine clinically. We don't just look at radiographs and spinal balance, rib prominence, because many of these children have a prominence in the back of their spine, And we looked at all of these. No difference clinically between the two systems that we could determine. Okay, so maybe it has something to do with the interoperative. So we looked at perioperative outcomes. And if you look at the operative time, look at the power of randomization. The difference is 0.9 minutes between the two procedures. I mean, that's an astounding similarity. But in terms of transfusions, ability to walk, discharge from hospital, you know, there's some differences back and forth between the groups, but no clear pattern and nothing statistically significant. Okay, finally, complications. Maybe the complication rates are different. Well, there's two of the most dreaded complications after spine surgery. One is neurologic complications, and the other is loss of fixation, meaning the hooks that we had attached to the spine came apart. And when you look, there is no statistically significant difference, but if anything, the complications were higher in the USS group for both of these. So we couldn't find any patient-based outcomes that made a difference. We couldn't find any clinical or radiographic changes, and we couldn't find anything related to the perioperative experience, and we couldn't find anything related to the complications of surgery. So, the trial concluded that the two instrumentations were exactly the same. Moss Miami was slightly cheaper. So what happened after the trial? Everyone went back and did USS. And we continued to be a USS center. George Bush said it best, "I know what I believe, and I believe what I believe is right." I'll just digress here. Obviously, this is now 2 presidents ago, and I love this slide, and I've used it I try and get it in every talk just because I like the quote so much. And I used to talk in the United States. In the North, I would present this, big laugh. In the South, no one smiled. So what does this study say about orthopedic surgeons? We have trouble accepting new information that doesn't conform to our expectations. Everyone thought the USS was going to be the better spine system. It was stiffer. It was going to correct the scoliosis better. Patients were going to be happier. Didn't turn out to be the case. So we had trouble accepting that new information and, in fact, essentially rejected it. So this is another book which you may not have heard of. It's also, it is written by a Canadian journalist named Daniel Gardner. And his primary focus is what he calls the science of fear. How do we as humans respond to fear? And of course we respond very illogically, presumably because in our distant past that was important for our survival. And I think he introduced me to this concept of the confirmation bias, which you're probably all familiar, which is once we formed a view, we embrace information that supports that view while ignoring, rejecting, or harshly scrutinizing information that casts doubt on it. So this is confirmation bias. And there's some really interesting work by a researcher at Emory who's done functional MRs. And he puts people in the MR machine, Republicans and Democrats, and shows them sentences and quotes that are either supporting or criticizing Republicans and Democrats. And what he's shown is we process that information differently in our heads. So if you're a Democrat and you see something related to a Republican, it goes to one side of your brain. And if you see something for a Democrat, it goes to another part of the brain. And of course, the implications of that is we're hardwired. So this is not going to be easy if that turns out to be true. So confirmation bias, I believe, is one of the more pernicious biases that confronts clinicians, that makes it hard for us to accept new information. And we see it everywhere. This is a very difficult bias that pervades our society and goes all the way from not just the clinical arena, but up to the highest levels of government. I suspect if I show this in the South, I won't get a smile either. So I want to take you back to Bruce Moseley's study because there were some legitimate criticisms. This was just a single trial. Clinicians appropriately said, it was the wrong patient population. So this is a subsequent trial, also published in New England Journal. Sandy Kirkley, who tragically died in a plane crash with her husband, posthumously published this trial in a much more select and ideal patient population for arthroscopic debridement. Their conclusion was arthroscopic surgery for osteoarthritis of the knee provides no additional benefit to optimize physical and medical therapy. That's not the end of the story. Surgery versus physical therapy for meniscal tear, because surgeons then said, well, it's not the osteoarthritis, it's the meniscal tear that we need to treat. In the intention to treat analysis, we did not find significant differences between the study groups in functional improvement over a 6-month randomization. Although there is a caveat because this was not a placebo-controlled trial. However, 30% of the patients who were assigned to physical therapy underwent surgery within 6 months. So it didn't appear in an intention to treat that was any benefit, but there was significant crossover. Well, then there was arthroscopic versus sham surgery for degenerative meniscal tears. In this trial involving patients without knee arthritis, so these with symptoms of degenerative meniscal tear, so the most select subgroup of patients for which this should be a good procedure, the outcome after arthroscopic partial meniscectomy were no better than those after sham surgical procedure. So why is it so hard for orthopedic surgeons to accept that arthroscopy isn't useful for early osteoarthritis? Well, a patient presents to their surgeon with pain. Surgeon does a MR. Sure enough, there's a meniscal tear. Surgeons go in, they do an operation. Sure enough, there's a meniscal tear. They take out that meniscal tear. And when the patient comes back, they're better. So everything is telling you this is a good procedure. But there are alternative explanations for why it seems like a good procedure, but it isn't. There's this thing called regression to the mean. Patients present when their symptoms are bad. And if any of you have had low back pain, you know if you just wait, it goes away. So for some of these patients, if they'd done nothing, the knee pain would have got better. There clearly is a placebo effect. Surgery is among the most effective placebos in all of clinical medicine. Just having, or what you think is having a procedure, often makes you think you're better. And we have to accept that a certain number of patients just want to please their surgeon. It's hard to come back and say to the surgeon, Doc, I'm no better than I was before. So it's hard for surgeons to understand why arthroscopy isn't good for OA of the knee, but it almost certainly isn't in the vast majority of patients, and certainly those over the age of 50 or 55. So to take you back to Daniel Kahneman's book, he talks about System 1 and System 2. And System 1 is what gave you associative advertising. System 1 provides the impressions that often turn into beliefs, and it's the source of impulses that often become your choices and actions. That's why you're going to reach for that Heineken tonight, where you might not have before I showed you that ad. And he goes on to say, the best we can do is compromise. Learn to recognize those situations in which mistakes are likely, and try harder to avoid significant mistakes when the stakes are high. And I would suggest to you there's very little other situation where the stakes aren't as high as treating patients with surgery. It wouldn't be easy, but we have to accept, or I believe we need to accept, that maybe there are situations in which we're not making the best decisions for our patients. So, this is where I think it's time to begin to move from thinking purely about generating evidence and evidence-based practice, but begin to think about how are we going to change surgeons' behavior. And you'll be familiar with this term implementation science, which has been in and around for about 10 to 12 years, although obviously for many, many years we've been trying to change people's practice, but this is now a formal discipline. And my belief is if it's going to be successful, and I believe there's increasing evidence within implementation science that it's going to need to involve all the stakeholders, not just the surgeons. I think the public and patients have a role, health managers clearly have a role, and we need to both choose the practice change, and I've suggested to you we need structures to support clinicians in making those change. We're also going to need to bring in the professional associations. For orthopedics, this would be the British Orthopedic Association in the United States, the American Association of Orthopedic Surgery, the Canadian Orthopedic Association. The professional associations have a major role in influencing how this rolls out. And this is in a largely untapped opportunity to engage the broadest community, both physicians and patients, through social media, to get their feedback and get them on board in changing behavior and practice. Once we're confident, we know what the best practice is. So, to conclude, I believe doing the right thing for patients is going to require us, as surgeons, to change our behavior. I'm not a psychologist by a long shot, but hopefully through some of the studies I've suggested to you, the findings would suggest that changing surgeons' behavior is likely a complex task. And it's almost certainly substantially influenced by bias and heuristic. Heuristic being these automatic choices we make based on the impressions we have, which come from the system one. I also believe that real change can only come from surgeons. This has to come from the surgical community. They have to be the leaders in this, because otherwise, if they're told what to do, it will just disenfranchise them. And I also think we're at risk of making bad decisions. And finally, surgeons may be less human than other humans, but I believe we're still human. So thanks very much.